everyone, welcome back to the Tox Lab. I'm Rebecca.
And I'm Rob. This week we're not looking at a niche poison or a novel drug.
Sad times.
We're looking at something much more fundamental, but also, and I can just feel our numbers dropping off, something which I think at first glance seems less exciting. But bear with us, because I think it's actually really, really important. And really the premise this week is, if you take a number in toxicology, can you interpret it? Can you interpret a number in general? So if I told you, right, if I told you someone was driving their car at 70 mile an hour, what does that mean?
I need context.
Precisely. If they're driving on the motorway, that might be completely reasonable.
Yeah.
If they're driving past the primary school...
Bad.
Bad, correct. Toxicology, we love a number.
Yeah.
We love knowing how much of some poison or some drug is present. But, crucially, can you just interpret that number, or do you need to know more information? And that's really what we're going to be looking at this week. The information that surrounds the number and how that contextualises what we're looking at.
And we are just under, when this episode goes live, a month out from the joint TAFT meeting in Chicago. And spoiler alert, we are going to be there. We're going to give some talks. We would love to meet as many of you as we can, hang out, chat. So if you're going to be there, please send us a message. We'd love to hear from you.
Yeah, definitely. Really looking forward to it. So, I'll give you a number. What does it mean? Intro us to our first paper.
So interpreting results in toxicology is hard, and many of us know that it's really challenging. Lots of different factors need to be considered, like observed clinical effects, the circumstances surrounding the case, individual drugs and drugs in combination. So a big question is, does detecting a drug in toxicology actually mean someone has been poisoned?
And I think that this is the CSI generation.
Yeah, I feel like that's...
We'll see dramatised versions of, oh, we've detected X and therefore Y, or the other way around.
Yeah.
And you're right. How often do we look at drug results or poison results and have to make a judgment call as to whether it's significant or not?
And there are a couple of opposing biases that also come into play when interpreting tox results. So one is the unproven ingestion bias. So this is instances where studies claim toxicity in the absence of confirmatory lab testing. So there's a couple of quite famous-ish examples of this. It often occurs in paediatric patients where exposure is suspected but was never witnessed. For example, Dr. Levy evaluated this bias in a poison control centre of children suspected to have ingested methanol or ethylene glycol, and only 20.6% of all the patients actually had positive toxic alcohol levels detected. And it was assumed based on their presentation that these particular toxins had caused this issue.
So I've definitely had cases where children were found in the presence of a bottle of antifreeze.
Yeah.
And therefore testing was carried out. Now, in defence of anybody working in paediatric ED in that situation, ethylene glycol is really, really sweet tasting.
Yeah.
And I'm told children do like to drink it, although it must have bittering agents put in to commercial antifreeze.
Surely.
But also, you don't want to gamble it, do you? You don't want to take the risk.
No.
And even though you've got a completely healthy patient in front of you that's otherwise, running around causing trouble in children's A&E because they're 3, you still don't want to miss something.
Yeah. And there is another argument. Measuring concentrations of lots of drugs and poisons in many circumstances for many patients doesn't really change anything. It won't change their management, and that number is kind of meaningless. So it can lead to confusion around the interpretation of that result, increased burden on the lab, can be expensive, and increase processing time and time to treatment if you're waiting on a result in a particular number for a case. And it is also important to note that even if a patient has a negative result on a toxicology screen, it doesn't mean they hadn't been previously exposed to something, or that there's a risk of significant exposure to something, and that also plays a role in patient management.
What do you mean by risk of exposure to something?
So, in cases with children who were found next to a bottle of antifreeze, for example, yeah, they may not have drunk it that time, but you can't completely disregard the circumstances because there was a situation where a child was at risk of harm.
Put your antifreeze in a cupboard.
Yeah.
But I see what you're saying.
So the other bias is detection bias. So this is a bias where qualitative or quantitative laboratory detection is believed to equate with clinical toxicity.
So in other words, you've got a patient who's unwell, you do a drug screen, they test positive for cocaine metabolite. And the assumption is that that is what has caused their presentation.
Yeah. And it's important to take into account the history, physical exam, and response to any potential therapies. And qualitative serum or urine results, and even quantitative results, don't indicate the time of ingestion, the dose that they ingested, contributing effects of co-ingestions, into individual variability, so tolerance to a particular substance, or the role in producing a clinical effect in a certain situation.
All fair, but why do we bother testing at all in that case?
Like, testing is important because it does tell you what is present at a particular time. I just think the limitations of that result need to be considered. So measured concentrations don't always correlate with the clinical effect or impairment, and you see this in measured concentrations of THC. And levels can remain high even after a period of abstinence. They might not be under the influence, but they're still testing positive, and that can complicate things. And there are other drugs such as paracetamol that can be eliminated from the body, but their toxic effects still persist. Where it looks like you've got a patient who's presented with a paracetamol overdose, they've got liver toxicity going on, but they're not testing positive for paracetamol, doesn't mean that it wasn't at play in the beginning.
That's completely fair. Yeah, that's fair. I think you're right. I think that this is one of those areas where you could show me a set of results or a set of concentrations, and I could probably, I'd like to think, have a reasonable go at providing some helpful interpretation.
Yeah.
But you're right, that helpful interpretation would almost certainly be this result could be associated with this, but could be associated with normal use in a tolerant person.
Yeah.
Or, you end up caveating your interpretation to the point where it's not helpful to somebody who's in A&E with no further information than I've got a patient in front of me and they've tested positive for cocaine. Yeah, I think that's a completely fair point.
And so the other question is, how much evidence do we actually need as toxicologists before we can say that a drug caused someone's presentation?
And this is really interesting. Presentation, let's extend this metaphor to post-mortem. How much evidence do we need to say it caused or contributed to death?
So there are many factors that need to be considered that we've already discussed. So clinical presentation, history of the patient, findings from the lab, the concentration that you've measured, responses to treatment, co-ingestants, and alternative explanations for their presentations as something completely organic that might be going on. And there has been 9 criteria proposed by Bradford Hill in 1965 that can be used to assess causation between a predictor and an outcome. And this includes strength of the argument, consistency, specificity, temporality, biological gradient, plausibility, coherence, experiment, and analogy. So for temporality, the ingestion of that substance has to coincide with the symptoms. It can't be something that's happened 2-3 weeks ago.
Yeah, that makes sense. And that sort of feeds into plausibility as well, doesn't it? Something could be biologically plausible, but part of that is whether or not you'd expect an amount of that concentration to be significant at that point in time relative to when it was ingested.
Yeah, and I guess that also plays into biological gradient. As the concentration of something goes up, you'd expect the clinical effect to be amplified as well.
Yes, it's really tricky though, isn't it? Because this is one of the big challenges of evidence-based medicine versus the real life day-to-day. We love to do big studies with lots of people and generate population-level data.
Yeah.
And then we take a single patient and try to interpret it against population data. And that's where a lot of the uncertainties make everything really hard. Your THC was a good example because that really, really is variable depending on how often somebody uses it.
Yeah.
2 people can have an identical number and one can be as stoned as you can ever imagine.
Yeah.
And the other is fully functional and completely fine and walks around with a measurable THC of that concentration. And that's partly because what's going on in the blood isn't what's going on in the brain.
Yeah.
And that's partly because people develop actual tolerance to the drug. And it is a real challenge, actually, within toxicology. I mean, the classic is in drug driving and drug impairment. I mean, that is a classic question. How high does somebody's cannabis need to be? How high does somebody's blood THC need to be before they're impaired?
Yeah, it's almost an impossible question, isn't it?
Exactly. Unlike alcohol, where there is a reasonable line that you can draw on a graph between blood alcohol and risk of crash, that same relationship doesn't exist for THC.
Yeah.
So I think really the takeaway then is that exposure, detection and poisoning, none of those mean the same thing.
Yeah.
And I guess when you say it out loud, that sort of makes sense. But there is a risk that toxicology reports are over-interpreted.
Yeah, for sure. So here's a question. In a world of AI, can AI interpret toxicology result, or can it only recognise the drug that's present?
Okay, so put me up against AI, who wins? Well, we're currently recording this in August 2026. This episode might age really, really badly, because in 6 months, maybe I'm out of a job. I think it's an intriguing question. And I make no shame that I like to use AI as a tool in my day-to-day life. I think it's really, really helpful. I don't yet trust it to interpret toxicology, but I appreciate things may change.
So this work was actually brought to our attention at the most recent London Toxicology Group meeting back in June. And this paper looks at evaluating AI chat performance in interpreting anonymised forensic toxicology results and comparing these against published expert opinions with reference to forensic practice. So they pulled 10 published case studies which contained drug concentrations, sample details, an expert toxicology interpretation, demographic information such as sex, age, location, and a little bit of case history. And these cases covered a really wide range of drugs, single and polydrug use cases, fatalities and hospitalizations, different specimens, different ages, circumstances and countries. And these cases were summarised into short prompt and entered into Microsoft Copilot and ChatGPT 3.5. The outputs of this were then assessed against a framework. So they looked at drug identification, whether the AI correctly or incorrectly identified the drugs present, the number of caveats to interpretation that were included, the errors in interpretation, risk categorizations, whether the interpretation was classified as fatal or life-threatening, and the confidence tone. So they categorised them as overconfident if the large language model used definitive language without qualifiers, so strongly suggests or well within the fatal range, or they classed it as appropriate if they included qualifying terms, so may suggest or consistent with, or acknowledged uncertainty about the case.
So how did the AIs do?
The AI correctly identified the toxicological agents in 9 out of 10 cases, so 14 out of 15 compounds, with both large language models incorrectly identifying desalkylgadazepam as being the same compound as desmethyldiazepam.
Ooh.
So yeah, not a great one.
That's interesting that they both got it wrong.
Both LLMs frequently use the same confidence tone and were overconfident with their use of language and conclusions despite uncertainty within the data. And this occurred quite frequently and was seen in 7 out of 10 cases and overlapped in 6. The number of caveats that Copilot used ranged from 0 to 5 with a mean of 1.3 and 1 to 7 for ChatGPT with a mean of 3.9. But this doesn't include the caveats that were mentioned in the actual paper. They screened out those because obviously it can access that information.
Yes, and this is going to be one of the challenges of this experimental design because they were using published authentic cases.
So there is always a risk that the models have found the papers and can then adjust their interpretation accordingly or found references to the papers that they're using.
And that's how large language models work, right?
Yeah.
They predict what the next character is going to be.
Yeah.
If it's been trained against that case, it would likely regurgitate a lot of that case word for word. So that possibly does completely screw the experimental design in this case.
I think the way they phrased the prompts was very bare bones. It was, we have this case and this is the drug concentration, interpret, rather than giving all of the details, which would then allow them to quite easily match it to the published work. So it was slimmed down, slightly targeted at trying to get it to do its job, basically.
Okay.
The overall number of errors was also small, with 3 errors for Copilot and 4 for ChatGPT. Other than the misidentification of desalkylgadazepam for both, errors included comparing post-mortem and ante-mortem serum values directly and commenting on the manner of death based on a drug concentration alone, when in reality you need the circumstances, the pathologist's findings at post-mortem to come to a manner of death conclusion. The language used by the AI often included mentions of definitive fatal ranges without the nuance that these are only previously reported values associated with fatalities. And the lack of nuance and overconfident phrasing was definitely an issue with the AI interpreting its results.
Yeah, I found some of the interpretations were really quite enthusiastic.
Yeah.
And not necessarily wrong, but phrased in a way that was quite definitive.
Yeah, it made it seem like that was definitely the answer.
That's it. That was the answer. Not this is one possible answer, because there's actually, as we know, there's always many.
Yeah.
It's classic, isn't it, that a toxicologist can find a drug at a concentration that could be consistent with fatality, but without knowing that the person hadn't had their head removed by farm equipment or something like that.
Yeah, exactly.
It's not possible to say one way or the other. And I've definitely encountered cases where I've detected potentially fatal concentrations of drugs, and the cause of death was nothing to do with that drug.
Yeah. And the AI's general approach to interpretation was quite scattergun. So there are mentions of drug interactions in cases where only one drug was present. They didn't mention drug interactions where there were lots of drugs listed. Lots of things along those lines.
The thing I liked most was Copilot's not only enthusiasm to be very definitive about its conclusions, but then how it would suggest, having delivered an enthusiastic conclusion, how it would suggest that it might draft that into an official court-ready report for you.
Yeah. It's quite scary, isn't it?
Yes. Yeah, definitely. Definitely. But that said, so the models that we used were actually out of date now.
Yeah, they're using ChatGPT 3.5.
We're now up to 5.6. And anybody who's been using things like ChatGPT will know that models have really improved in these last, few months alone. But over these last few years since it launched, the models have got a lot better.
It'd be interesting to see if you put in the exact same prompts that we used in this paper into the newer models, would it give you the same answer? Or would it start to include more caveats and, understand a little bit more nuance?
And the other thing is you can train them to do nuance.
Yeah.
You could write a prompt that says, don't be overconfident, do include reasonable alternative explanations and alternative caveats. So you could definitely engineer it to be better than this paper revealed.
Yes, but with people using AI to interpret results, how often are they going to write a prompt that gets the AI to give an answer that includes nuance and considers alternative explanations? I think that was a large point of the paper, is that if, for example, family members were putting results from a toxicology report into ChatGPT to get an interpretation, they're not going to be considering all of the other things.
Yeah. No, that is completely fair. That is definitely something I have encountered.
So both the AI models were comparing, in a couple of cases, post-mortem concentrations and comparing that to ante-mortem concentrations that it had found, and then trying to interpret them like for like, which is definitely an issue.
Yeah, I mean, it does depend on the drug.
Yeah, always, but
some drugs actually work quite well. But yeah, that's completely fair. You need to know what you're doing, I suppose, to be able to draw those conclusions.
Because you've got things like stability of drugs within samples and different sample types across post-mortem cases was another issue. You've got the difference between cardiac blood and femoral blood, and they behave very differently. You've got post-mortem redistribution of drugs, which again is another factor that I don't feel like the AI can consider when it's comparing post-mortem and ante-mortem concentrations.
Yeah, I think that's fair. So, big question then. Are we going to be out of a job anytime soon?
I don't think so.
Okay, confident. Confident.
I think there's so much nuance that comes with interpreting toxicology results that I'm not sure an AI would ever get to a point. And this might look really bad in like a year or two, but I don't think an AI would ever be good enough to account for all of that nuance and interpret a result and put together a report in the way that humans can.
This is a clip that's going to come back and bite you in
really
6
is.
months.
Yeah.
I think where I currently draw comfort is the fact that even if the computer can do it, nobody trusts the computer. So
that's fair, yeah.
You still need a human to provide the delivery currently. But
you never know how that will change.
Absolutely. Yeah, no, you're absolutely right. I don't know where we're going to be in 6 months or a year, to be honest. But as it currently stands, according to this paper, AI was relatively useless. Or, no, that's unfair. AI was reasonably good, but missed a lot of the nuance.
Yeah.
And that's crucial. Okay, so, final paper then. More interpretation.
Yeah. So between April 2022 and March 2023, there were 9,690 hospital admissions in the UK related to drug poisoning, equating to 17.3 per 100,000 population. And this also doesn't account for the number of presentations to the emergency department with acute recreational drug toxicity who did not get admitted to hospital. And there are currently no interpretive guidelines to define whether a measured plasma concentration indicates mild, moderate or severe exposure, and instead relies on clinicians looking at isolated case reports, pharmacokinetic studies or forensic datasets. Tolerance and inter-individual variability also need to be accounted for in addition to polydrug use. So this study proposed a descriptive clinician-facing framework based on ante-mortem data from multiple contexts to provide clinically meaningful reference bands for interpreting plasma drug concentrations in acute care. So for illicit drugs, plasma concentrations are classified as low, moderate or high based on percentile thresholds derived from published data, and prescribed meds are described as being within or above their therapeutic range.
So the premise was then, big literature search, find lots and lots of studies and try and establish effectively, in inverted commas, reference ranges to interpret drug concentrations against. So before we dive too hard into this one, let's go back to that first paper. Because that first paper claimed that these numbers are all meaningless.
Fair.
And so here we are now trying to interpret them against all of these wider studies. Okay, well, let's run with this. Let's see where we go.
They conducted a literature review looking at 24 different analytes, which included parent drugs and clinically relevant metabolites. 79 studies met the inclusion criteria, containing 1,216 ante-mortem plasma concentrations. 47 studies and 697 of the plasma concentrations involved illicit substances, which were delta-9-THC and its carboxy and hydroxy metabolites, 6-MAM, amphetamine, BZE, cocaine, GHB, ethyl glucuronide, ketamine, MDA, MDMA, methamphetamine and morphine. 32 of the studies included 519 plasma concentrations covering prescription medicines, which were alprazolam, buprenorphine, codeine, diazepam, EDDP, gabapentin, methadone, pregabalin, tramadol and zopiclone. And it is important to mention that there is crossover between what they've classed as prescription medicines and what they've classed as illicit substances, because morphine falls under the illicit, whereas morphine can be legitimately prescribed and used for pain relief. You've got alprazolam that's included as a prescription medicine, which isn't licensed in the UK and other countries, and is often abused. So there is that overlap.
Oh, that makes sense.
So the studies covered emergency department presentations, ICU admissions, drug-impaired driving evaluations, studies of controlled administration, and therapeutic drug monitoring. And the data covered a broad range of plasma concentrations from nanograms per mil to milligrams per mil, reflecting differences in pharmacokinetic properties, doses, different routes of administration, analytical sensitivity, and sampling time.
So massive study of lots of different papers.
Outliers were identified using a Z-score of plus or minus 3.5 and were excluded on a case-by-case basis where inclusion would significantly influence the thresholds that were selected. So some of them they kept in because they felt they were important, but if they really skewed how they were sectioning off the different ranges, then they excluded those.
Okay.
Morphine, for example, had a wide range of reported concentrations but a narrow therapeutic window, and interquartile thresholds were selected. But drugs such as cocaine and MDMA with broad concentration effect profiles and larger sample sizes were categorised using tertile cutoffs or thirds, creating low, moderate and high exposure ranges. Low concentrations frequently overlapped with values reported on controlled administration settings or non-toxic exposure studies, whereas high ranges covered concentrations reported in overdose cases or cases of severe intoxication. And the aim of this was to provide a framework for clinicians to interpret a number that they're given, but there are many caveats to this.
So ultimately then, we've got a big table. We've got a load of numbers and somebody comes into I&E and the premise is we measure their concentration of cocaine in their blood, we get a number and we can say, this person's not got a high cocaine, this person's significantly intoxicated. Or at least that's the premise.
And this is the issue I have with this. So you could detect two different drugs that are both present at low concentrations, you think probably aren't related to their presentation, but if they have the same sort of effect, that element of polydrug use and like synergistic effect comes in. So is a clinician going to pick up on the fact that yes, these both are low, but they produce the same effect, so therefore in combination, that's going to be an issue.
So that's one drawback so far, the combination effect.
You've also got timing around the ingestion or the administration of a substance and then the measurement as well, which can influence things.
Yes, that's a good point. So depending on how recently or how distantly something's been administered, it will probably change categories a few times, potentially.
And it also doesn't account for tolerance as well in an individual.
Well, that was my big one.
And that really does, as I'm sure many of you who work in Tox Labs know, tolerance plays a big role in how we interpret results.
That was where I was thinking, because I was thinking a controlled administration study might detect nanograms and a small cohort of people occasionally using a drug might have a little bit more. But when somebody is using a drug regularly, people can sometimes tolerate many, many, many times what a non-tolerant individual could take.
Yeah.
And that doesn't necessarily mean they're experiencing any significant toxicity from it.
Yeah, I always think there's a really nice paper on oxycodone concentrations, and I think it's out of Finland, but correct me if I'm wrong, but looks at different groups of people who are on oxycodone, so cancer patients who are obviously on really high dose oxycodones, people who are in hospital for different things but are regularly taking oxycodone, and others. And it's such a wide range of concentrations that people can experience without experiencing toxic effects.
Yeah, that's it. So it does kind of skew all of this high, medium, low. You will always get somebody who is extreme high.
Yeah.
And basically none of these numbers will mean anything.
Yeah, there are always exceptions to the rule for definite. So why can't we simply use the concentration that's been measured to calculate the dose that someone took of a drug?
Oh, I mean, this is a classic question, isn't it?
Yeah.
Absolutely classic question. So I'm going to put it back to you that there might be situations where we can. We sometimes do back calculations with alcohol.
I know that's one you can do it in, and that there is literature to back that up. I don't think I'd feel comfortable doing it with anything else, but that's just my opinion.
Possibly could in really controlled pharmacokinetic studies. So
Yeah.
if, for example, you did a pharmacokinetic study where you give differing doses to people and produced a range of areas under the curve and so on,
Yeah.
and then took a patient who you randomised to have a dose, you may be able to have a reasonable stab of guessing which dose they had. It would depend very much on the drug.
Yeah, and there's lots of individual variation that comes into play as well.
I don't know what circumstance you'd ever do a study like that.
No idea.
Seems like a really odd thing to do. But in general, you're right. You know, if I get a toxicology result, if I measure a drug in a person at a given time and get a number, I can't tell you how much of that they've had. If I knew when they took it, could I have an estimate?
I don't think reliably.
You're challenging me here, because I think you could.
I'm just thinking about how variable individual pharmacokinetics can be and pharmacogenomics and how many different variables you have to take into account that
You certainly wouldn't be able to measure it to the milligram.
Yeah, I don't think I'd feel...
That's fair.
Maybe you could say that it was many more times their
a big
prescribed dose
versus a little dose.
But any more than that, and I feel like you're playing a dangerous game.
This is all hypothetical. I'm not saying I'd actually do this in real life. Interesting. It is a classic question, isn't it? It's a classic question we're asked. How many pills did they take, or how much drug would cause this? And yeah, you're right. It's not something you can easily answer, if ever, especially without knowing timings and tolerance and all sorts of other things.
Yeah.
So what's our verdict then on these reference ranges? Helpful?
I could see them possibly having a role in very specific situations, but I think there are so many variables that the data can't account for that I wouldn't want a clinician looking at a number going, that's not toxic, when it could be. Or vice versa, going, that's definitely toxic, that's the reason for them presenting, and there's something...
Let's not do a head CT and miss a massive brain bleed. Yeah.
And something else organic that's going on that can completely account for their symptoms. I think it needs to be taken in the context of the clinical picture, and other things need to be ruled out before you place that weight on a tox result.
Yeah. So I do want to caveat this work. Because there were several of our colleagues who wrote this paper. So I do have to acknowledge somebody, or a lot of people, did some really hard work on this.
Yeah, for sure.
There was a heck of a lot of research gone into finding all of these studies and compiling these ranges. So I don't want to poo-poo on this too hard. Where I think it could be really helpful, actually, is not presenting it alongside a toxicology report to a lay interpreter, but I think it could be really helpful for people with knowledge of toxicology.
Yeah.
As a combination of sources to provide this range of potential interpretations.
Yeah, and they did acknowledge in the paper that this would obviously need to be tested in real clinical scenarios, looking at a clinical presentation of a patient and their measured tox result and see where it falls in those different bins and whether that kind of matched what they were seeing. So it may, for some drugs, work really nicely. For other drugs, maybe not so much.
I think that's probably going to be the case. Yeah, I think that's probably right. I guess the big question is it better than just drug detected, which was where we were with that first paper.
Yeah.
Considering biases and are we over or under interpreting, that sort of thing.
Yeah, it's tricky.
Yeah, it's all very interesting. There's a lot to kind of consider, isn't there?
So a question that I don't think we can answer, but what makes a concentration toxic?
Oh,
I've got some really good questions this week.
I don't like this, you asking me the questions. This is a question with lots of levels, because now my brain is running off in a few different directions.
Yeah.
What makes a concentration toxic? Well, the really obvious answer to this is, well, a higher concentration's got more drugs per unit of blood, and therefore it's doing more stuff.
Yeah.
Is that the answer?
Well, it's an open-ended question. So.
But that same number in two different people may have two different effects.
Yeah.
Therefore, there's no such thing?
I think that's fair. I don't think you can very clearly define a concentration where something moves from not being toxic to being toxic. I think it's very individual dependent, scenario dependent, and I think that's where interpretation gets tricky. And people want a nice easy answer that this number means this thing, but in fact, as we've seen through all these papers, there's so many different caveats that we've got to account for when looking at a number in a case.
Yeah.
That you can't clearly define what a toxic concentration is.
No, I think that's really fair. Now I'm worried I've overinterpreted numbers in the past. Do you know what I mean?
Yeah.
Like, I think you're right, actually.
So I think this plays quite nicely into my final question. Can a toxicology result ever tell you the whole story?
My default answer was no.
Yeah.
And then I'm trying to think, are there scenarios where it could? And I think the answer's still no.
I don't think that toxicology has all the answers and can give you
It definitely doesn't.
the whole story in any situation.
What do you mean by the whole story?
Like, a toxicology result isn't going to tell you necessarily on its own in isolation why someone is dead. It's not necessarily going to tell you in isolation why someone's presented to hospital.
No. No, okay. Yeah. Yeah, no, I think you're right. No is the answer. No. And this is why we need toxicologists to interpret these things.
Yeah. And interpretation is messy. And I think the more you think about it, the more unknowns come up and the more things that need to be considered when we're looking at numbers or case data.
If anything, I feel like we're more important than we were at the start of the episode.
Well, that's quite a nice place to be, isn't it?
It's been a heck of a discussion this week, hasn't it?
Yeah.
I've really enjoyed looking at this because this is something that you pretty much take for granted, right? You do it day in, day out. You write reports, you think about interpretation. Don't actually sit there and think, what's the framework that this is happening within, and are things being over or under interpreted? And
yeah, I think it takes stepping back and looking at the whole picture to realise how important our jobs are to make sure that whatever interpretation we provide is neither over nor under interpreted, and that we use all of the other information that we have access to help form our opinions.
And going back to the AI, it's interesting that the AI seemed to over-interpret it rather than under-interpret it.
Mm.
Because I think the default response is to provide a cautious interpretation.
Yeah. No, it is interesting. I don't know whether it's just because all it got given was someone is dead, here is a number.
Yeah. Yeah.
Here is the drug. Write an interpretive comment, tell me what's going on.
Yeah. Interesting.
Rather than having lots of, I think if you gave it more detail, it might be more cautious.
Although, that said, by giving it more detail, surely
it will just find the interpretation, won't it?
Oh, well, that. But also, in general, you know, the more information I know about a case,
oh, the better your interpretation
the
will
more
always
refined
be. Yeah.
my interpretation will always be.
Yeah.
Yeah, absolutely.
Yeah. It is strange that its default is overconfidence rather than cautious, whereas I feel like a human is more likely to be cautious rather than overinterpret.
Agreed. Yeah, agreed.
But I think that's part of the nuance of toxicology.
Yeah, definitely. Well, I hope you've enjoyed listening to us this week. It's been a good discussion. I've had a great time.
Yeah.
If you've enjoyed listening, do like, share, reach out, leave us a comment. We love hearing from all of you.
Hope you all have an amazing week, and we'll see you next time. Bye!